Human Services Committee to order. Wait a minute, you can't go anywhere. I need a quorum. Where are you going? I mean, wait a minute. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. Okay, here comes Carla. Now you can go. So, okay, we're teetering on our thing. Okay, Representative Kirby, House Bill 473. And before you get started, I want to make sure you have not put anything in here, have you, that would allow us to bring our personal pets on the last 2 days of session? No. Good. I had somebody inquire if we would be able to do that. And when I asked about what kind of pets, I said, you know, she was surprised that, you know, we might own boa constrictors or some kind of unusual pet.
We could check with Chairman McCall, maybe some cows on the floor might help move things along or something.
I've already checked with the speaker. We won't be bringing our pets on the last days of session. So anyway, you know,
Am I on?
you know, an interesting thing for somebody to ask. I'm glad they asked instead of just trying to bring their pets the last day. Okay, go.
All
This
right,
is House Bill 473. It has been revised. It's in your folders.
Yes, ma'am, and we're working off of LC 337250S. You know, the process when we follow it through over the last 4 years has worked very well, and I want to thank this committee. When this idea was first brought to me, the people said, you know, a simple idea of having a photo ID with a person and their service animal would be easy. And a lot of times, as we all know, those simple ideas don't always make good law. And as we worked through it and some of the comments last year we had, and this year in this committee, we had to really break that paradigm because that was kind of stuck in my head. So what I've got now is what are we really going after? And that's the fake service animals. People bringing their pets instead of service animals into too many institutions. So the meat of this bill is now really the last paragraph where it always should be. And that is on page 4, starting in 104, and that's if they willfully misrepresent their pet, trying to claim it's a service animal. And I think that's where we need it to be. It's a misdemeanor, fine not to exceed 2,000 or 30 days. You know, because these are where the real problem is. It's the problem for the service animal community is the fake service animals. So if you back up and look in what we talked about last time, we took out animal, replaced it with dog. We're talking about dogs, so there's no confusion on peacocks or ducks or anything else. It is service dogs that we're dealing with. We also took out anything with the mental impairments. Those are a little harder to, of course, be seen and really not the majority of what we're having to deal with when we're talking about the visually impaired community and where we see most of the service dogs active. So we took all that out, replaced. We still got the part about the trainers, so the trainers are the actual owners of the service dogs, or give them the same latitude, and that's not changing any law, working straight off the ADA, and really putting in that definition of this on line 27 on page 2, where a service dog means a dog that is trained and actively being trained to assist to work or perform tasks that a physically impaired person, which is actually utilized for the purpose of aiding that such person performing one or more major life activities, and provided, however, the term should not include a dog solely providing comfort, emotional support, or companionship, because those are simply pets. With this, the apartment association, the restaurants, the grocery stores, wherever you go, it gives them the ability to tell people, you know, your pets are not allowed here, but that service dog is still allowed here. So with that, I'll be happy to answer any questions on the substitute, and I think after all your hard work and comments from last time and work with Legislative Council, I think we've got something that can work and help our service animals, service dog community, and also give the businesses the tools to make sure the pets aren't coming where we don't need them.
Okay. Representative Kirby, did you have anybody from the apartment association or the restaurants or the grocery stores, anybody come up and talk to you?
Yes, I've talked to the people representing them, Hayden Stanley with the Apartment Association, different groups throughout this whole process that have been very supportive.
Okay, and they're okay with this bill?
Yes.
Okay. Representative Silcox.
Representative Kirby, thank you for your revisions. And I just wanted to make sure that everyone knew also, isn't it true that you also took out the card provision?
Yes, 100% of the card was removed. I'm sorry, that's the biggest change. No card at all, because it just didn't really fit, and I think some of the concerns, especially if it got to be so second nature that people were expecting people in Georgia with a service animal to have a card, and somebody came from another state, they wouldn't have one, and it could cause them problems, and so we just removed that totally. It's decided it wasn't needed.
Okay, Representative Drenner.
Thank you, Madam Chair. Representative Silcox asked one of the questions that I was interested in about the card provision. The other question is, which agency had finally accepted responsibility for this?
Once we decided after the last meeting that we didn't need the card, we didn't need any agency involved in it at all.
Does the fact that it's now a misdemeanor, if somebody wants to complain to the police
Yes. And gives
would
them
have
the
the right to
tools.
charge them with a misdemeanor?
Correct.
Okay, thank you.
Representative Peak.
Thank you, Madam Chair. I just want to follow up on your question. You mentioned the Apartment Association, but the Georgia Restaurant Association obviously has got a huge interest in this bill. I've had a couple of conversations with them about it. Have you specifically had conversations with the Georgia Restaurant Association, which represents thousands of restaurants all over the state, where this is a daily encounter and a daily issue?
Yes, we have had conversations with Karen, and the Restaurant Association does a great job trying to teach and train people on
Right.
what the rights of service
Right.
animals are, and, they've been kind of right there, I wouldn't say side by side, but following along everything we're doing as we're trying to give them and
Okay.
give you as a restaurant owner some tools to help
Yeah.
you when you have that problem. So
Yeah,
it's-
because we sure want to accommodate folks that come
Yes.
in, and, but it sounds like you've gotten, and the improvements in the bill, I think, have gotten us where we want to be, so thank you for working on that. I just wanted to be sure that we'd gotten the green light from the Georgia Restaurant Association, so I'm assuming you're going to continue to
Yes,
have dialogue
and
with them. so-
we'll continue this conversation. We still got the
Okay,
other side of the building to
yep,
deal
yep,
with.
thank you.
Right,
If
but
we
is
can
there
get through.
anybody representing the restaurant building here? A restaurant?
I didn't see him here,
Association?
Madam Chair, so that's why I was asking.
Wait a minute,
so-
we do have
Oh,
somebody.
there he is, there's Daniel, yeah.
You want to come forward and tell us who you are? Come over to the mic.
Hiding in the back.
I'm afraid we're having meetings on top of meetings, so they're probably covering other meetings.
Sorry, Daniel New with the Georgia Restaurant Association. We have spoken with Representative Kirby about this bill. It is something that we do support. I haven't seen the substitute language, but we do support accommodating anyone with any kind of disability. We definitely don't want to exclude them, but it would help our restaurants when it comes to the bad actors that we don't want, causing problems for us. It would help.
Thank you very much. Representative Schofield.
Thank you, Madam Chair, and thank you, Representative Kirby, for all the work you've done. I just have one follow-up question. What is the position of the airline industry
Oh.
in this bill? I'm sorry, I got to bring that up because this has been, who have you spoken, have you had conversations?
I have not. The airline industry is covered under the federal law where, now, and we certainly want to support Delta. Delta's the first one that I've heard of starting to fight back, because under federal law, if somebody says they need a comfort animal, no matter what that animal is, they basically have to let them on. And for the first time, I read just a short while ago that Delta's starting to say, no, this is a real problem. I would hope we could do something to help them at the federal level, but right now we're concerned under Georgia law and not what they're doing in DC.
So I'm concerned that the airplanes, that you list the word airplanes in this bill, that really does not reflect what the real issue is. It doesn't help these emotional service dogs. I understand it well, but
No, you say airplanes in this?
yeah, I see on line 35.
Let me, 35, let me remember.
So I was just wondering, have you had a conversation?
Well, that's just from the current statute right now for a service animal in
Okay.
Georgia.
Thank you,
So,
that's it.
Well, I think that would follow federal law
Yeah.
for
Mhm.
service animals now.
Yes.
Representative Hilton.
Thank you, Madam Chair. This may be wordsmithing on my part, but we'd be curious to kind of get your thoughts on physically impaired versus using disabled. Was there any discussion on kind of using one over the other? Impaired kind of denotes sort of temporary disabled permanent? I guess it's meant to kind of capture a broader.
I would have to defer
For-
legislative
to Betsy, yeah.
council on disabled or impaired.
Betsy?
Okay, perfect.
Is that all you need?
Mm-hmm. Thank you.
Representative Newton.
Thank you, Madam Chair. I appreciate it, Representative Kirby. On line 29, it mentions defining what a service dog is one that assists with performing major life activities, which, and obviously a seeing eye dog and others that we've had are pretty clear. When I look back though on line 19, and it defines a major life activity as interacting with others, it makes me wonder if we have opened up a door that anyone who claims that they need their service animal to interact with others, I know even though we expressly in 30 and 31 exclude companionship and emotional support, I'm kind of lost in between those. So I was wondering if you could help me understand how interacting with others is a major life activity for which my animal helps, but and then all the way at the end, obviously it's a misdemeanor if I misunderstand that as a member of the public and think that interacting with others is a major life activity. I have a dog that helps me with that.
That wording comes right from the ADA. That's how they define major life activities straight out of the federal law. And that's all we did was mirror that. Interacting with activities would be like the wounded warrior that I've met that you could say interacting with others and walking. He can't go around a corner without the dog clearing the corner. He can't enter a room without the dog clearing the room from his stress from serving. Without that animal, that service animal, he has no ability to interact. Even people walking up behind him, as he said, when they did it in Baghdad and I decked them, it was a good thing. When I did it in Kroger, it wasn't so good. The language straight out of the ADA, I understand your concern, and we try to tighten it down as close as we can, but I think if we took out the actual ADA language, we'd probably be opening up another issue that we maybe don't want to.
Okay. That's all the questions that we have from the committee. Do you have anybody signed up to speak on it? No. Okay. What's the pleasure of the committee? Okay. I have a motion to do pass and a second. Is there any further discussion from the committee? All right. We're ready for a vote on the substitute to House Bill 73, LC 337250S. Everyone in favor say aye. Anyone opposed, say no. The ayes have it. Thank you very
Thanks, Madam
much.
Chair.
I will tell the committee, as this bill, if it moves forward and goes over to the Senate, if it goes to the Health Committee in the Senate, I think that chairman would like to see us study this over the summer. I would hope if you have any interaction as it goes forward and that becomes a problem, that you will try to help Representative Kirby out and say this is a good start. If we want to study it further, as far as comfort dogs and all, that maybe that can be done in a study committee. But he's done a lot of work on this, and I would like to see this, if it moves to the Senate, that we support our colleague and help it move through the House. Thank you, Representative Kirby. Okay, let's see. All right. I think there's going to be more discussion on House Bill 769, so let's go with House Bill 161. Representative Price. She's here.
Thank you. Thank you, Madam Chairman. Is it on?
It's
Am I
on.
Okay. Thank you, Madam Chairman, members of the committee. I'm sorry I was detained elsewhere, but thank you for hearing me at this time. This is House Bill 161, which is a carryover from last year, and it's regarding the basic concept and overarching theme of exchanging and providing and making sure that people have access to sterile needles.
Representative Price, before you get started, are we working off, I want to just make sure we have the right one, LC 337243S?
Yes, ma'am.
Okay, so we got the right one. Okay,
I believe
sorry to interrupt.
that's the correct number. I'm sorry I didn't mention that. So the basic thrust of this bill is to assure that people have access to sterile needles and that they have a safe deposit for used needles and syringes. And the bill basically makes it so that someone who is part of a syringe services program or an SSP is not held liable for having those goods, those paraphernalia, shall we say, that normally are limited to a pharmacist and other practitioners licensed to dispense dangerous drugs. So it inserts the category of syringe services program, and the definition of that program is listed on lines 16 through 24, which are all encompassing for providing an integrated approach to HIV prevention and for education, for referring to entities that would be helpful if someone was using illicit drugs, also for counseling, also for the ability for them to receive perhaps pre-exposure prophylaxis, post-exposure prophylaxis, and all the other things that encompass capturing someone at a site where they would be getting clean needles. Also, to screen for STDs, tuberculosis, and to provide access and treatment to hepatitis, the various forms, vaccines, hepatitis A and B, and also provide services for medical, social, and prenatal patients. So this would be very, very helpful to reduce the incidence of these diseases that are very costly in both human terms and financial terms to society and have been shown very effective in other places. And this would be administered or authorized by the Department of Public Health, authorized to promulgate the rules and regulations for the supervising of these SSPs. And this is very, very similar, slightly different wording and slightly different encompassing compared to the bill that passed last year.
What were the changes, Representative Price? I mean, not the specific wording, but in general?
Basically, it's harm reduction organization was the terminology used previously, and it was more limited in the types of counseling and other access to other treatment modalities of a number of social programs that would be connected to illicit use of intravenous drugs.
So to make it clear, we're not just going to hand out needles
Correct.
and send people on their way, that they have to have access and offer counseling, testing, and be a total wraparound program trying to get these people into treatment and off drugs. Is that correct?
Correct. The goal is to not only minimize the disease and the spread of disease, but to obviously curb behavior, modify behavior, and get people into a better lifestyle.
Than they have. Okay, questions from the committee? Representative Henson.
Thank you. Do we currently have a clean drug program or a place that folks can go and get clean needles here in Georgia?
The liability for anyone who does that is not clear in our law, and that's the point here.
But I mean, do we have a place? Do we have places that people can go that are drug addicts and that want to access clean needles so they're not sharing and using dirty needles? Because I just remember having dealt with something like this years and years ago.
Representative Henson, I do believe there are groups that do go out and give people clean needles
Mhm.
and try to encourage them to get into treatment. But right now, that's basically against our law. And we need to clarify that so that people can actually set up a more comprehensive program, and that it won't be illegal.
This is really to hold harmless those people who are doing it within the confines of the auspices of the Department of Public Health.
I didn't know. And then when we begin talking about the different types of, not just the testing, but the counseling, at that point you need to get into professionals and all. Would this be administered at departments of public health? And where's the funding coming from? I mean, it sounds like we're going to be needing quite a bit of funding because it's going to involve, you know, skilled practitioners. They're very knowledgeable in their areas.
This would be for referral primarily, and there's no fiscal note attached.
If it's just for referral, if they're just referring someone and these folks don't have money, then who's going to treat them? Who's going to help them?
Well, there was federal law in 2016 that did provide appropriations for that. So I guess they can apply for that, get grants, what have you. But as far as it coming out of our Georgia budget, this would not affect our budget.
And it becomes effective when?
That would be upon, it's like all our laws that become effective on July the 1st.
Thank
If
you.
it's not specified otherwise.
Mm-hmm.
Representative Newton.
Thank you, Madam Chair. Just a real quick question. The list of syringe services program organizations, what they offer is a pretty long list, and it looks like it's and. Is it the intention that those organizations would have to offer all of those services to be qualified as a syringe services program that the Department of Public Health?
There are a number of semicolons, so they're not necessarily.
Do you think they can pick and choose of those, or they have to do them all? Just really a clarification point.
Right, I think.
It's a pretty.
It is an exhaustive list, but that was requested of the bill to have it exhaustive so that it would be inclusive in the reach of what
More than a needle exchange, right?
exactly,
Right.
to get them
Thank
into a location and a place where we can then make sure that they get the kinds of services they need, if not right there somewhere.
Thank you.
So, finished? Did it? Okay, Representative Reinders.
Thank you, Madam Chair, and thank you and thank the author of the bill for recognizing some of the issues the committee had last year as it was overly broad and trying to tighten it up. Really a good job. I think we also had some questions as it related to the Department of Public Health last year, so let me start there if I may. As it relates to any of these organizations that are offering these much needed services, are they required at any point to register with the Department of Public Health?
Well, given that they authorize these entities, I would think they would have to be within that, yes.
And I frankly couldn't agree with you more, but I would hate for an entity that didn't know that they had to do that to somehow be held liable, since that's the purpose of the bill. That I would think that we should have somewhere a friendly amendment that says, and registered by the Department of Public Health, so the Department of Public Health has a mechanism to make sure that they're being able to do the kind of treatment and help that the purpose of the bill wants.
If you think that that's outside of rules and regulations that they would develop, then I would agree to that.
Is anybody here from the Department of Public
Okay.
Health?
It's not in there. What? I don't know. Betsy,
Yeah,
is
and my
it-
point would be, I'd hate for someone to think they do this and y'all not know who they were.
Yeah, sorry. My name is Katie Kopp with the Department of Public Health, and the sponsor is exactly right. That is something that we would put into rules and regs. So I won't speak on her behalf, but I would consider that a friendly amendment. But it's also something that we would do in rules and regs. So.
I'll defer to the chair then on that. I just don't want someone opening up with great intention and all of a sudden be cited because they didn't know they had to do something because they weren't familiar with the rules and the regs, because we're trying to do this the right way. But thank you so much for your hard work on this. Thank you, Madam Chair.
Betsy? Do you think it'd be better to put it in?
I mean, I definitely think that rules and regs could take care of it, but if you want to specifically require that, and then you could, add on to line 12 that it's the agents of registered syringe services programs, and then, add some language down with the rules and regulations, the things that they'll include.
Madam Chair, if there's no downside to that, I just think that if they read the law and looked it up, it would be something that would do exactly what we're trying to do, which is provide that kind of liability.
If it makes my former vice chair happy.
Ma'am, I'm
Try
here,
to accommodate
I'm always
for
here
you.
about your happiness,
Yeah,
ma'am.
I know. Such a mutually caring society we have. Okay, Betsy, what is it again? Is the amendment, will everybody listen up?
Okay, yeah, we're gonna change two things. The first one's gonna be on line 12, before the word syringe, at the end of the sentence, put the word registered, so it'll say an agent of a registered syringe services program.
Okay, has everybody got that one? On the registered syringe service program, okay, Betsy?
Line 24, at the very end of that sentence, to tack on to the end, it says, including provisions for registration of such organizations.
Okay, including provisions
For registration of such organizations.
for registration?
Include that when they, promulgate the rules and regs.
You want to say organization or program?
You're right, program, well, line 17, we use organization.
organization.
Probably programs.
Okay.
Programs. I think either could work, but programs really makes sense.
Including provisions, the end of line 24, including provisions for registration of such program.
Right.
Got it? Everybody got that one? Okay. Do I have somebody that's willing to offer an amendment on that?
So moved.
Second. Okay, I've got a motion and a second. Let's move on this amendment and we'll go. Okay, any discussion on the amendment? What? I'm gonna let you, I'm not gonna, you want it on that?
Well, yeah, we need to ask a question into that.
About the amendment?
Yes.
Okay, sorry. All right, Representative Sharper.
Okay, thank you, Chairman. On line 16 and also line 24, before you say of like syringe service programs, do you need to put registered before syringe on those two lines?
I don't think so on 16, because at that point, they're not registered yet. That's
Okay.
just sort of defining who could be eligible to be registered. And what was the other line?
24, so that'd be the same thing then. Right before syringe.
Yeah, that would, yeah, I think we can add it there.
Nice catch.
Where are we doing it?
On line 24, before syringe.
Okay. On line 24 would be a registered syringe services program, okay.
It's kind of redundant and
Would it be, pardon? That's where you want to put it?
Yeah, 'cause
Well,
it's-
he was just trying to be consistent with the terminology there. We use the term syringe services program, so we're just adding register in front of it.
Okay.
I think that the
Because if it's
comma-
not registered, it's, you know what I mean?
Right.
We gotta make sure it's registered, because if you're not saying it's registered, it's not registered.
It just makes that sentence awkward, but I don't think it's any problem.
Is there any other suggestions before we now move on with that addition to the people who made the, move on the amendment, are they okay with that addition?
I move that we accept the amendment as amended.
As amended. Do I have a second? I wonder what the rule is. Can we only amend it once like it's certain? No, never mind, I'm teasing. Okay, don't go there. All right. Everybody in favor say aye.
Aye.
Anyone opposed, no. All right, so we have the amendment. All right, did I get everybody who wanted to discuss it? All right. All right, do I have a motion for passage?
Move
Or-
we pass House Bill 161 by committee substitute.
As amended? Or by substitute? Okay, by substitute. All right, I've got a motion and a second. Any more discussion? Okay, Everybody in favor say aye. Anyone opposed, no? Okay, no? Okay. All right, we'll take a hand vote. Everyone in favor of the passage of the substitute to House Bill 161, raise your hand.
Am I allowed to vote?
Okay, yeah. Okay, did you get it? Okay, Leo's got it. Everyone opposed? Okay, all right, we have it. The motion abstain, okay, the motion passes, and we have noted the no vote. Thank you very much. Next up is House Bill 895. If you will go to your folders, you have a packet of information on this and a picture of the states showing we have DXM restricted states. Okay, this is about one of the components of the medicines that we find in cough syrups. I think that the drugstores, sell about, what they say, about 50,000 products, in, these over the counter. But as young people seem to do, they seem to be able to find a way to abuse most anything. And they are now abusing DXM and becoming impaired. And this is a bill that would move to limit that and have, not to put it behind in the pharmacy, to make it, or have a registry where you have to sign for it. But just as young people were checking out, if they look to be younger than 25, that they be asked to show a driver's license. And if they are under the 18 or under, it will not be sold to them. So, be glad to take questions. You have a sample of all the kind of medicines that you had that have DXM in them.
Proper time, Madam Chair, move to pass.
Okay, we do have a question. Y'all hold on that. Second, okay, Representative Henson.
Thank you. What about women that are head of household and under the age of 18? We do have some in Medicaid that have children that are no longer. Are they considered an emancipated minor, if I remember correctly, is the language that we've used in the past? What about that situation?
Betsy?
Yeah, they're emancipated minors still are subject to age limitations, say for alcohol, things like that. So, I mean, you could specifically exclude them if you want that not to apply to them. And so a 16 or 17-year-old that's emancipated could do that. I don't know what kind of paperwork they're going to show the Publix pharmacy or whatever, but, but yeah, I mean, you can add that in there. But right now, it would still apply even if they're emancipated until they're 18.
Representative Reynolds.
Thank you, Madam Chair. I appreciate Representative Henson's comments, and I didn't know if she by chance saw something that is problematic with the current language.
I was just asking a question with regard to somebody who would not have a guardian or parent that would be under the age of 18 and how, but I don't imagine that's something we could come back to if we needed to.
And Madam Chair, the reason I ask that is because I know that this committee is always making sure to do our due diligence to make sure that all Georgians are served. So if there was something that was spotted, I always welcome the opportunity to have that discourse.
First, I'm really not familiar with the drug. I know it's something you can buy over the counter. I know that if I was sick and went in and didn't have a doctor's prescription, I would ask what is the most effective, and I would probably be handed that. And that was just my concern.
Did you have an amendment that you wanted to make?
No, I think I basically was asking a question on that. Betsy answered it. I guess if we end up finding that we have a problem, then we could always come back and amend it at or add it or change it at a later time.
Okay, Representative Petrie.
Thank you, Madam Chair. Is there someone here who can speak to,
Right.
this document here mentions itself a small percentage of adolescents and young adults that do this. I'm interested in the degree to which this is a problem, because we've got kids all over the country that are eating Tide Pods now. I mean, where do we go next? I mean, what else are we gonna ban? Or require that young people, that put age limits on what people can buy? So is there some way of understanding the degree to which this is really a problem? Is there anyone here that can speak to that? I'm curious.
I don't know the percentage. We're trying to get out ahead of it from becoming the next item that we want to put behind the counter. We worked in collaboration with the Pharmacy Association. We're trying to avoid that. The thought is that asking as a deterrent their age, that will hopefully curb the activity. I can get the numbers for you.
Thank you, Travis.
Somewhere 8% or something sticks in my, it is a small amount, Representative Petrie, but it is a growing trend across the country. We're usually at the back end of trying to do something. And if we don't curb it, what will happen is we will get to the point where have to put it behind in the pharmacy, and you'll have to register and go through the hoops to get it that way. So nothing is perfect. It's up to you how you want to vote on it, but like I say, young people seem to be able to find, I'm waiting for them to be able to get intoxicated on toothpaste. Probably coming. I don't know. If it seems like the one. Representative Silcox.
Thank you, Madam Chair. I was just curious if there were alternatives, there were other medicines and cough syrups that children can take that don't have this drug that are effective.
Do we have somebody from the pharmacy board here, or the pharmacy? Where are they when we need them? And we're missing our pharmacist on the committee, huh? I don't think so. Just curious. So, this seems to cover the majority of it, but it doesn't mean that they can't get it. Representative Fry, if a parent gets it for them.
Thank you, Madam Chair. Representative Petrie, just to kind of answer your question, I don't have any statistics on this, but I did want to speak in favor of this legislation. As the father of a 12-year-old, this is going on in 7th grade all over, as far as I'm told. And we're still at that stage where he reveals to me every single thing that's going on. I'm sure that'll shut down soon. But just as recent as Thursday of last week, 2 13-year-olds were taken out of the Chick-fil-A where everybody's hanging out doing this, and they mix it with Sprite and Lifesavers, and they have a name for it. And he told me the other day, and I totally forgot it. I had no idea this was coming up, or else I would have written it down. But this is going on, and I appreciate the legislation because I think it will deter some of those middle schoolers from trying to do this thing.
I mean, it's the sins of the few that make it difficult for many to work through it. So, Mr. Lindley, are there any states that have lowered and since the age to 16 or anything on the restrictions? No, it's all have cut it off at 18? Okay, just a question. Okay, we got everybody? Okay, we're ready for a motion?
Motion to pass.
Got a motion to pass? Second. I've got a motion and a second. Any further discussion? Okay, everybody in favor of the passage of the substitute to House Bill 895, say aye. Aye. Anyone opposed? No. Okay, the ayes have it. Thank you very much. Thank you, Representative Fry, for that antidote, which is very timely. Thank you very much. With Lifesavers and Sprite.
I'll get the name for you by the next meeting.
Oh.
McDonald's is looking for a new product.
Yuck. Oh, I forgot. You own McDonald's, don't you? You have it. Do you get that and you don't have to pay? You get refills? Oh, did you pay for them? Oh. Okay. So that, maybe that, oh, thank you, but I think maybe that's why they're in McDonald's, is because they have, you know, they have as much Sprite as they want. So, okay. Hey. Wait a minute. Hey, guys. Hey. What is it?
Lean.
L-E-A-N?
L-E-A-N. I think it's L-E-A-N.
Okay.
You specifically announced that it passed a substitute House bill. Travis wanted to make sure you said substitute.
Okay, we have a
L-E-A-N.
L-E-A-N, Lean. Okay, guys, just to make sure, that was the substitute to House Bill 895, and that is what we passed, correct?
Correct.
The substitute. Apparently somebody didn't hear it, or I didn't say it.
The national percentage is 3%.
Okay, the national percentage is 3%. But that's an awful lot of children beginning to use it and growing. Okay. All right. And now, last but not least, one of the reps that has traveled the state with me.
Absolutely, Madam Chairman.
I bet you never get a broken windshield, do you, in your pickup truck?
Well, I'm just a little bit above maybe those flying rocks.
Yeah, right. I am now on windshield number 3.
He's in the bullet zone.
Oh, that part, from hitting rocks in rural Georgia. Okay. Pardon?
God's country.
Do you have disposable windshields down there? Okay. Okay.
I thought that white people got white cars because they could be seen easier.
What?
I'm not familiar with that.
White people's got white?
No, I didn't say white people. I said people bought white cars because folks could see them easier.
Cars, oh. Well, you know, apparently the rocks in South Georgia don't understand that I'm driving a white car. They've got me on their list to hit with rocks. Okay, House Bill 769, Representative Jespers.
Thank you, Madam Chairman and fellow committee members. During the last summer, our Rural Development Council met 9 different times all across our diverse state. Chairman Jay Powell and Chairman Terry England and their staff traveled with us, they great notes, and did a lot of research to help us. A lot of issues were brought up, all that were important to Georgians. But healthcare stood out. It's something many of us have a passion for. Many hours of council's time were spent listening, questioning, drilling down on the real issues and causes of needed healthcare in Georgia. 2 meetings that were specifically about it were those in Metter and in Bainbridge. And if you haven't looked at the website that's on our website that covers these, the videos are there, the documentation that was given out is all there. If you need to check back and look at it, it's very well done. To getting started, this is a sub. It's a 337321, of course, S. And that's I'll be presenting that sub. I really got to thank Legislative Council. Betsy, who we all point to many times, and from Chairman England's office, Martha Wigton, Leo Chansey. I've got to tell you, these are amazing Georgians. They're smart, and they help put things like this together that come from a lot of different directions. So let's get started. Section 1, as was discussed in our Metter meeting, it's remote order entry. Now I'm going to give you some detail because I want you to understand what's going on. There's a lot of people signed up to speak, but for me, this addresses the retention of pharmacists and the quality of life for pharmacists in rural Georgia. This was a recommendation from the group down there. So what goes on in a hospital right now is a doctor, after examining the patient, transmits the prescription to the hospital pharmacist, transmits it. Every hospital in Georgia must have a director of pharmacy, a Georgia licensed pharmacist on staff. The hospital pharmacist then reviews the patient record, places the order in the appropriate drug therapy in the patient's record for a nurse then to use. The process is very controlled, safe, and effective. The medications are controlled by sophisticated cabinets for distribution of the medicine to the right person. They all work together just like a 3-legged stool. What remote order entry does is allow the pharmacist who is following the rules and directions and regulations by code and by national organizations, the pharmacy board, and those of the hospital they're working with to look at the doctor's order, to look at the patient record, evaluate the dose, and place the order in the patient's file for the nurse to use. If you listen to what I said first, the second paragraph, the same. The Georgia licensed pharmacist is now only allowed to do this if located in Georgia. The bill on line 17 would allow a Georgia licensed pharmacist to do this in the United States. I have to tell you, we're the only state in America that does not allow this. The American Society of Health System Pharmacists recommends this change. And if you'll look in the things I provided in your packet, this sheet right here shows that. Take time to read it. I appreciate it. We typically only read the underlined thing in a committee on a big bill like this, but I want you to skip down to lines 47 and 57. And that's the directions that happens here. The hospital must have written policies, rules surrounding remote order entry, and if misused, will be halted. Georgia's safety is always in our thoughts, and I've got two. I could have had many more of these from rural hospitals agreeing to House Bill 769, but it's got two that I have in your thing right now. Because when we go back up to line 39, we're changing 24 to the next business day. This is in response to rural hospitals and their needs, and the pharmacists who attend them. As I said earlier, all hospitals must have a director of pharmacy. He or she could be one person in a small hospital in rural Georgia. The change will allow them to take time off, increase their quality of life. The remote pharmacist would look at all the prescription drug orders, the patient records, including test results, to complete the physician's request. They also look for errors that are made. These are professionals. They're Georgia licensed pharmacists who do this according to very clear agreements in the service hospital. On lines 40 through 42, we're removing lines 41 and 42. For those who are not lawyers on this committee, you can look at the I, and 3I as having the word or between each of them. When I figured that out, it really helped me. So, under II on line 40, if a pharmacist is in the hospital, going on rounds with a doctor, as many do now, or in the hospital safety meeting, or whatever they can do, they can turn to remote order entry to keep everything moving smoothly. As always, there are written directions, as we talked about 2 times now, concerning this. 3I is a very important one because it allows for remote order entry over the weekend by a pharmacist in a Georgia, in a commonly owned hospital. We trust it there for more than 48 hours over the weekend, possibly. So why not let a rural hospital trying to survive, needing remote order pharmacy when the pharmacist's not there to do this? There's not been a problem with it in Georgia, and if there were, I know that we would have heard about it with specific examples of why this wasn't working. Okay, in section 3, we move on to still in matter, and billing was talked about. And I wish you could go back and watch the lady from the rural hospital talk about billing. What a passionate woman who is trying every day to get the most money from all the different programs into her hospital. And what was amazing to us as members to listen to was the network of the people in the billing departments as they try to figure out ways to negotiate this. So what we're doing in section 3 is really just asking our friends at the Department of Community Health, and I say friends with an exclamation, to look at it. We make some recommendations, a long list of them in here, to please look at these for rural Georgia. You know, you talk to any billing person and you say that you're going to work on this, a great smile will come over their face. Please do this. It's really burdensome, and it would sure help them. It really adds a lot of expense. You know, we're not telling them what to do. We want them to try. And I really think this is one of those things that would help Georgians and help the providers meeting the needs of Georgians. On line 78, I want to draw your attention to one that I think is real important for our safety net hospitals, our FQHCs. This is going to allow billing for multiple specialists and multiple encounters on a single visit. So if you're an elderly person driving in to FQHC with 2 people, 2 physicians you need to see there, it'll allow for that multiple billing. I think they're working very hard on that right now. Look on, as we move along, we're looking on line 84. I think when we were there, and I think Chairman England in the 2 summers before has really been looking at rural health care, saw there is an absolute need for further training. And line 84 creates the Rural Center for Healthcare Innovation and Sustainability. Now, kind of gets a little complex here, but it's under DCH, and then their Office of Rural Health. That's based in Cordele. And they're going to be the ones that are going to get this thing going. They're going to work to improve the access to health care in rural Georgia, and that's what they do right now. So they'll work well with this. They're going to coordinate a request for whatever, I forget the name now, for the selection of a post-secondary institution where this thing will be located. The purpose of the center is to address issues we've heard during the council meetings. They're going to develop best practice curriculum and provide training for using the curriculum for rural health providers. This will include hospital board members and authority members. Think about it. These people are great people in Georgia, all over our state. They're business people from many walks of life, but are the hospital administrators. We want them to know as much as we can to be as effective leaders and effective administrators as they can, and also to train hospital executive leadership. The curriculum shall include many things, as you'll see in the bill: legal, fiduciary, grant management, planning, and compliance training. If you look on 99 through 101, there is a penalty for not playing in the game right. It's huge. It's a heavy hitter. When Chairman England, I asked him about it the first time I saw this bill, he looked me very squarely in the eye and said, "That's right. I mean business, and we need to mean business to make sure the hospitals and those fall in line and get trained to their need to." Let's go to section 4. Talk about micro hospitals. It's kind of been the one everybody's talked about. You know, 135 talks about the definition. 141 talks about the definition of a micro hospital. We're changing it from 35 to 50,000. You know, many times in this committee we've heard it takes around 45 to 50,000 people in a community to support a rural hospital. So that's why that's there. On line 146, we're talking about CON, or the real parts of this. You know, like it says, the purchase of a closing hospital or a hospital that's been closed for no more than 12 months by a hospital in a contiguous county to repurpose the facility as a micro hospital. And you kind of go, why? I mean, you know, when I first look at this, if you're not familiar with this world, you got to put yourself in that community's shoes with a closing hospital. I've been beside one. It's traumatic. You know, they've tried to sell it. They've tried to do every free market thing that they could think they could do. There weren't any takers. This proposal gives the community a chance and opportunity to help its citizens who for many years have supported a rural hospital in their area. Micro hospitals would be emergency care. Micro hospitals would be a place for pre-op evaluations as well as post-op sites for looking at it. Imaging, testing, whatever the site could support from the other hospital. If you're thinking about CON, if that's in your mind, I really bring out that, let's say if it's 30 beds, that CON will stay with the micro hospital and the community that supported that hospital in its originals. Section 6, I don't have to tell you much about doctor shortages. We all have talked about that many times. You know, we're doing great things to create doctors in Georgia. Look at Mercer and Morehouse, all the good stuff. But when they get there, they need our help. And in Article 2, we're talking about a grant program that is, of course, subject to appropriations, with the Georgia Board of Physician Workforce shall establish a grant program to increase the number of physicians who remain in our state and serve the rural areas of our state. This grant program shall work and provide premiums for medical malpractice. doesn't say that, but that's what it's gonna be doing. There are eligibility rules on line 167. Georgia Board of Physician Workforce works in this now. They have a grant, another different grant program to bring specialists into rural areas, so it fits right into what they're doing. In Section 7, something that's in place right now is the Rural Hospital Tax Credit that most of us voted for. We want to move it from 90 to 100%. You know, there's 2 or 3 bills out there floating between the House and the Senate that will do this too. You know, if you've heard about the Gold Fund for private scholarships to private schools, it's a similar thing as this. The goal, which is at 100%, sells out within hours every year. Currently, this one only raised $10 million out of the possible 60. And CPAs tell us they can get a better deal elsewhere. So the people that are doing that. I know for a fact that this $10 million has saved one hospital. They don't get all the $10 million, they get a portion of it. The maximum they can get is $4 million, but the dollars one hospital received really helped them in this past year. And you know, we all voted for this last year. It passed unanimously. I think probably maybe 1 or 2 no votes in similar legislation last year. This will make an impact. I think when we, in just summary, you know, I think those who are on the Rural Development Council have had an honor to be on it, and that they've had an opportunity to look across Georgia and see things that will make an impact. And we feel this rural health bill that we've all worked very hard on will do that. Madam Chairman, I'll be glad to try to answer any questions, and I've got all sorts of experts behind me to answer them if I can't.
I'm sure you're gonna have questions. I would think, my board hadn't lit up yet. Questions from the committee?
I got one.
Oh, okay, well, hang on. Okay, go ahead.
I know there's an uptick in Medicaid reimbursement for smaller hospitals. Did y'all talk about that or hear that from the hospitals? Like critical care hospitals or, Mark, are you familiar with this? Medicaid actually, typically on the larger hospitals pay 80% of cost, but that payment goes up to the smaller hospitals is what I've been told. Did you hear that, or was that discussed?
Vice Chairman Hawkins would have to ask somebody from the Hospital Association to answer that. I don't know.
Is that right, Ethan?
Yes, they get 100% of cost for Medicare reimbursement.
What's the bed limitation on that?
25 beds for critical care.
Good. That's what I thought. So we're under that 25 beds, so this will help them with their Medicaid reimbursement.
Yeah.
100%. Good.
Thank you.
Okay, thanks.
Representative Reinders.
Thank you, Madam Chair, and thank you, Mr. Chairman. I saw up close and firsthand the great work that you did, and I know this isn't an easy lift. I'm just a little question on line 93. And you know, you have my full support. I'm looking for the mechanism when we build this. On line 93, it says to rural health care providers. And I'm just, as we deal with an education curriculum, I see you've got some listed afterwards. But when we say providers, I don't think we can write this broad enough, but I guess I'm looking for an assurance of how do we address, since this committee's talked about everything from, I don't know, dentists to the pharmacists that we've talked about before, to other kind of providers. What kind of, I guess I'm looking for a little bit more balance instead of just my friends at the hospitals, executive leadership, board members, hospital authority members, to make sure that we have a cross-section of providers in that. And I don't know how you write that, by the way, but I just want you to know that in my mind, that's an issue.
And Chairman Reinders, I think if they do a great job, which I'm certain they will, and our post-secondary will take it very seriously, that those will be brought in as part of, in a hospital, they'll probably bring all their providers. But we're saying that group you mentioned must go. We've got to have them go to fulfill the needs that Chairman England, I think, is really seen lacking throughout.
And it is lacking. There's a lot of lacking in healthcare providers beyond just hospitals. And I just want to make sure, how do we address the primary care physician piece? And those kind of things. And that's just, I don't know how to fix that, but I just want to bring it to the members' attention that this is deeper than just a hospital type of situation. Thank you so much.
Reverend Jansters, I don't really think that in this you're really talking about like physicians and all as far as a curriculum for them.
No.
This is not. This is talking about, and maybe it's unclear when we say healthcare providers, because that does seem like it's nurses and doctors and radiologists and all. We're really talking about more of the people that would serve on the board.
The leadership,
The
I think, is a
leadership.
great way to just, that we're after.
Yes, ma'am, and Madam Chairwoman, you're exactly right. If we're looking at this center and the leadership of the Center for Rural Health, and that's what this is in relationship to, as I read it, correct?
Yeah.
I didn't want just the leadership to be made up of, you know, in the past, we'll always say, well, make sure we've got one of this on there and one of this on there and one of that on there.
I think
And
maybe-
that can be something we look at down the road.
Okay.
But I would hate to see that we got a 7-member and 5 of them are hospital CEOs.
I don't.
Using that as hypothetical.
We'll get together, Chairman Reynolds, but I think on 92 and 93, it's that the center will develop standards for education curriculum provided to providers. That
Well-
it's not describing the board.
Right.
Is providers the best word for that, Jester, or hospital? I mean, leadership or leaders, I mean, really, what's the definition of healthcare
I'm just
provider?
looking for a balance somewhere.
Not defined for purposes of that, but we do, since the only ones that'll be penalized for not doing it is over on the top of page 4, rural hospital organizations. We could use that terminology, say something like the leadership of a rural hospital organization. That would be.
Well, I think I would have to say, because the penalty's so great and so clear, that you really need to define who they are. And I think that's what the bill does. It talks that the chief financial officer, every board member, every hospital authority member.
Right. It's just making it consistent,
Yeah, I
Reverend
think,
Jasper. It doesn't,
Chairman
Thank you.
Reynolds, I think that's, you know,
That
I
needs to
think
be-
I think as the center grows, I think we're just trying to get it started with a great idea.
I'm reminded of what the legislature did back in the 40s as it relates to the Board of Regents. And not having that oversight from a financial kind of perspective, even though we do their budget. And I know serving as chair of the One Georgia Overview, when we had a member come in and recently during the budget hearings talk about that, but we have that committee set up for the purposes of just in case something goes awry, we have a mechanism to go in there and make sure that we have a plan of corrective action. And as you move forward, just take those thoughts into
Yes, sir.
consideration.
I wrote
Thank
them
you so
down.
much, Madam Chair.
and Representative Jasper, at the right time, I'd like to make a friendly amendment on
Sure.
that
Yes,
line
ma'am.
of 93.
Line 93?
Yeah, rural healthcare providers instead. Betsy, what did you say we could call them that would fit in?
Like to the leadership of rural hospital organizations, actually as defined in 31-8-9.1. That ties down the rural hospital organizations, and that's defined in that other code section too.
And that's what you were defining anyway, that just makes it
Yes, ma'am.
clear.
Sure
that-
does.
That is doctor and nurses. Okay. Betsy, write that one down, and at the right time, I'll let you offer it. Okay, thank you. Okay? Okay, Representative Silcox.
Thank you, Madam Chair. With respect to Section 5, looking at lines like 150 through 154, I guess I want to understand that this would be the purchase completely of the prior CON. Don't know if you wanted to, again, add a friendly amendment to make that understood, that even though there's a major downsizing going on, that it would be completely the purchase of that prior CON.
I'd like to have somebody from DCH to answer that, because I think that's in there, you know, it's in the CON part, and this is an exception. And is Andrew here? Can he
Yep.
answer that?
Great, thank you.
Thank
Hey, good afternoon. Andrew Johnson with the Department of Community Health. So the CON in and of itself would not be acquired. You acquire the facility that has a certificate of need. And so effectively, there is no market for certificates of need. So it's, if you acquire the facility and it has an active CON, you get that along with the facility.
Okay.
Okay.
So that would be understood, do you think, clear by the language here?
You can't acquire the CON without the facility.
Okay.
So
So yes.
I think it's adequate, yes.
Okay, great. And then second, on the portion, I think it's here, lines 166 through 172, in terms of the premium assistance for physicians that go down to the rural areas. Just curious if by the grant program providing insurance premium assistance, would there be any implied immunity for those physicians in terms of the state?
What implied what?
Any
Immunity.
implied immunity from suit? Just curious if they
Oh,
would
no.
apply on their own on their own merits. I would think that would be important.
Yes, ma'am.
Okay, thank you.
Okay. Representative Hilton.
Thank you, Mr. Chairman. This is a great bill. Just two quick questions. Is there a fiscal note associated with the tax credit toward the end there?
The tag, you mean in
The increase?
the last section?
Yeah. Under
No, there's
section
not.
7.
No,
Okay.
there's not. There is a limit to 60 million. That can be,
Got it.
In the
the
previous
tax
bill.
credit can
Okay.
be up to 60 million.
And then, okay. So would there be?
Well,
I mean, the limit is 60 million, so it's a fiscal note.
Yeah,
You know
we,
how much it's gonna cost us.
yeah, we've authorized up to
That's
60
exposure.
million.
Got it. Got it.
but that's already in the law, isn't it? Didn't we?
Yes, ma'am.
That's already in the law.
Okay.
Yeah, it's
So
there. We're
this
just changing
Fiscal note would
90
go
to
along
100.
with, it would just be the 10% of the,
60.
We're
of the
trying to
60,
get
right?
people to do it.
Use a faster car getting there.
Yeah.
So
Could you also highlight for me, what else does the State Office of Rural Health do? The new, and I guess maybe highlight why we need to create a separate innovation and sustainability department. I'd be curious to kind of hear what other things they do or work on. I mean, what we have in this bill seems to be a pretty big and important thing.
Well, I think within the role here is they're going to be the facilitator of getting it started. If somebody we have now, they'll go out, create the RFQ of what we want, go to put it out there for our post-secondary folks to apply for it, to compete for it. And I kind of made a little list where you're looking at people like Georgia Southern, possibly ABAC, Georgia Southwestern, Valdosta,
Okay.
or it could be University of Georgia, because they'll have healthcare things. I don't know if that answered your question, but what else they do? Mr. Johnson?
Thank you, Mr. Jaspers. The State Office of Rural Health falls under the Department of Community Health, and they do a number of things, a number of the grants, some of the rural hospital grants and some of the other programs that this body has implemented and funded in recent years. The vast majority of what they do is administer those grants and does some data collection and things on what are the outputs and learnings from those projects. They have some rural primary care initiatives that they do. In regard to this, my understanding is that we would largely be administratively somewhat of a pass-through and would initially be responsible for doing the work to identify and bring on the university partner that would carry out all the things that you see in this bill, is my
Gotcha.
understanding.
Okay. Thank you.
And then Representative Hilton, also in the supplemental budget, there was $75,000 put in there to help this move along.
Got it.
Representative Newton.
Thank you, Madam Chair. Two quick questions, if you don't mind. One on the micro hospitals. Is there anything right now that prevents I don't want to say failing hospital, but a hospital that's about to close? Is there anything that prevents them from going down to 5 or 7 beds now? Or is there something special about calling it a micro hospital that alleviates other regulatory burdens?
There's nothing to prevent them doing that now. They kind of do that as their
As
bed
they
population
do it, yeah,
shrinks. I mean,
census.
they go to 1, they're not financially able to continue.
Okay.
I think this allows that neighboring hospital, to use their resources and funds to really prop it up is a better way to, it's just a plain way to say it.
I think that's what a lot of our areas need. Thank you. One last thing on the tax credit. Is it all the rest of the old tax credit language that limited the amount to maybe $4 million per hospital, or the way that if they reach the cap, which I think with 100% credit, we're going to reach the cap a lot faster than we did with 70 or 90% credit. Do we still have all the old language that
Yeah.
limits, so one hospital doesn't get 30 million or something, so.
No.
It's
Though
still
they're
the.
probably in who would like to, but,
All right.
no, sir, it's still 4 million.
Thanks for your
I
work
asked
on
that specifically today to make sure.
Thank you.
I have some questions on the micro that I may have to be somebody that answers it. Are there parameters on what a emergency room that's open 7 days a week and 24 hours a day? I mean, I can see in some of these communities, you know, there not being a huge amount of it making it a real and busy emergency room. I thought it was going to be almost like the new ones that they have, which are, what do they call it? What?
An
Well,
urgent
not
care.
convenience center. Huh? Urgent care centers. DCH, Andrew, do you know what all it must include to be? I mean, I guess what I'm asking is this going to make it, if a small hospital wants to go down to just, you know, the limited beds and run an emergency room, are the rules around the definition of an emergency room so huge and they have to have so much equipment? Does it make it impossible for a small hospital to do that on their own?
Madam Chair, that's a good question. And this ties into, I guess, Representative Newton's question about, is there anything preventing them right now? What they have for emergency services, what they have as part of their CON right now, it can be reduced right now down to 2 beds, 7 beds, 2 to 7 beds. Emergency services do, of course, require radiology services if we need to do x-rays, laboratory services to do tests, pharmacy services to provide medication, the ancillary services that you do need to support an emergency room. I would say that emergency care is the most expensive form of care. But if you ask patients and businesses from these rural communities, would they want to have an emergency room or no access to care at all in their community? Every single one of them is going to say, we'll keep at least an emergency room. If your family member has a heart attack or a stroke in the middle of the night or a traumatic car accident in the middle of the night, that emergency room could be the difference between life and death.
I guess what I'm asking is, I'm sure there's a difference on what CT scans cost. I mean, do they have to, you know, and certain things you could do if somebody has a cardiac a problem, are they required to keep the very expensive auxiliary machines needed for the extra test around?
Required? No.
Or just that we are able to diagnose that there's a coronary gone, it's very bad, that person needs to be transported to a bigger facility?
That diagnostic service, along with the radiology, the lab, and the pharmacy, those ancillary services are part of emergency care. And it does stipulate on line 142 that they provide those emergency services. But that's what's necessary for the hospital and what that community needs. And I think this gives them the flexibility to do that.
Okay, and so that as we develop these really expensive tests and so forth, doesn't mean they have to have those available. They just have to be able to make the initial diagnosis and see if a person is warranted higher intervention.
That's right. It would be for the stabilization primarily to make
Okay.
sure that, you know, you were saving lives. Now, if they did need a transfer, of course, they would already have that transfer agreement with the purchasing hospital, and that would be effectuated that way.
Okay, that's what I'm getting at. They don't have to, because I can see as much as equipment cost, and aren't there federal regulations that
There are
that
a
you
lot
have to
of
have
federal
new
reg-
equipment, CT scan equipment every 4 years, or, I mean, it's pretty exorbitant in the cost of all of this, and,
It is costly care, but these communities need that care.
well,
Yes.
I mean,
And there are a lot
I'm
of
not
federal
trying to keep care,
regulations.
I'm just saying if it's feasible, because not all of them are gonna be owned by a bigger hospital.
The micro-hospital provision does state that it would have to be owned. Where did it go?
Yes.
By,
The purchase of a closing hospital by a hospital in a contiguous county. That's down on
right,
line
that one doesn't
152.
do, if it's purchased, but what we were talking about, what about if a smaller hospital wants to go down?
That would be their choice, and I don't know that you would see a lot of them do that right now.
Okay, because of the cost.
Right.
Okay, that's what I was trying to figure out. And then I had another question on this one.
Yes, ma'am.
Why, we had a lot of hospitals that have closed in the last couple of years. 24 months? Why does it limit it
Actually,
to?
over the last 5 years, it's been, believe 8 rural hospitals since 2013.
Okay, so why does it have to be 12 months?
That's what the current CON law requires, that your CON, from the date you let the Department of Community Health know that you're going to close, your CON is active for another 12 months.
See, there's another reason that CON law needs to be changed.
No, I think it's just fine, actually.
Come on, guys, let's just pick,
Just my opinion, and of the hospital community.
Okay. Thank you, you answered my questions. Would you mark that down, President
I did,
Jasper? So that we
ma'am,
can-
I have. I've
I
made
mean,
2
those
notes
nice little
here.
hospitals are sitting out there that, want them 24 months, 13 months.
I believe we'll have the opportunity to discuss that.
Discuss that one. for the
We will.
Representative Hawkins.
Yeah, this was actually for Ethan. Ethan, would you come back up? I'd like to ask you this. You've been around for a while and understand hospitals. Is there any part of the hospital failures due to the absence of physicians or the difficulty of having physicians living in the rural areas?
Oh, absolutely.
Yeah, so I thought that'd be a good part of it.
To recruit especially a specialist to a
Right.
rural area, and the
Right.
expense of having that specialist available all the time is an enormous burden
Right.
for hospitals.
Right. And I looked at a lot of the presentations, but I'll tell you, I didn't look at all of them. I mean, you guys did a tremendous amount of work. I listened to hours and hours. And the Tifton was a really good one. But in all of that you heard, was there anybody addressing the fact that students are having trouble getting loans when they go out to the rural areas? Did you hear that? Because I know that when I talked to some of our dental students, they couldn't obtain loans going into rural areas when the banks looked at. This is not against the banks now. I'm not starting to fight the banks, because the banker I talked to helps the Georgia Dental Association, great guy, and he said, "Look, I can't make a loan that they can't pay. If they can't service the loan, then the loan goes dead. So do I. If I do it, they just replace me with another guy that says no." So I understand that. But was there any discussion of trying to make serviceable loan help to these people?
There was a discussion in one meeting, I can't remember which one, where you were talking, I know it was Mercer, Dr. Sumner brought that up. Thank
Gene
you.
Sumner? Yeah.
Yeah, she really did. And she talked about how that in rural Georgia, especially small towns that may not have a dentist or don't have a physician, are going to have to get their brain around becoming a partner. Because,
Right.
Those folks are not just providing that health care. They're small businesses. They create wealth. They create, just a spread out over community. And that's what I think she really hit on one time. And that's kind of stuck with me, her saying that. And I think this one little part that will do that. But that's something you might need to look at.
These students
that
are
may need to be done.
Yeah, these students are coming out with over $200,000 worth of loans, medical and dental students. And for them to service that and then buy a house because they're starting to have babies, they're married, they're 28, 30 years old, and to pay that with Medicaid reimbursement, that's where the problem really is, don't you think, Ethan?
I think that is very difficult for those physicians. I will mention that I believe it was 2008, 2009 timeframe when the General Assembly did pass a bill called the Assistance for Rural Area Physicians Act. And that allows I believe it's the Board for Physician Workforce, to make grant payments to physicians in order to recruit them to those rural areas and incentivize them to go to a place where maybe they're not going to make as much money,
Right.
or they may not be able to get those loans that you're talking about. But that
Right.
program has been very, very effective. And I want to say it was just a couple of years ago that y'all increased that amount available to that program. And it was very appreciated.
But it is one of the places, like Representative Jasper said, that in these rural communities, they often have businesses sitting empty, buildings and so forth. And, in some places, they actually go in and set up a physician's office and to entice the physicians to give them free rent or
Sure.
this kind of thing, which is one of the biggest expense, or, you know, I'm sure that probably somewhere has done it for dental too. And even if that dentist leaves after, or that doctor leaves after they've gotten 4 years of loan repayment, then you've got a medical practice set up, waiting for somebody to come in and say, here, you've got an office set up, you've got a staff set up, you know, come work, and if you stay 4 years, and hopefully somebody will like the community and stay forever, and that
Or
kind of
your
thing, but.
Representative Hawkins, or even, you know, for someone that owns a building in a small community, maybe an opportunity to have a bill that gives them, you know, the real estate tax, or, you know, or something that really incentivizes, because I think even with the real tax credit for hospitals, that 90, I would just amazed that between the 90 and 100%, that 10% change incentivizes action,
I
and
guess
it
the
makes a
point-
difference.
Right. The point I was trying to drive home was, without docs, you don't have much of a hospital.
That's right. We love our doctors.
Absolutely.
And our
Oh,
nurses.
that's so nice to hear.
And our nurses.
And you don't practice hospitals don't practice medicine, do they?
No, but we do take care of patients.
Yeah, well.
And so do our nurses.
Here we go.
Oh, no, it's left over from CON when the hospitals, you know, said they, you know, they're practicing medicine. Okay, Representative Reinders, I'm picking on him.
Thank you, Madam Chair. I appreciate Representative Hawkins in that point. I think it's Representative Hatchett and Chairman Cooper and Jasper and I going across state. We heard a lot of different things. We had one person that I thought was very interesting, because we talked about it later, that said, let me tell you, don't always buy into that people don't want to come here, because we have the low cost of living and we have this and we have that. But I think what we all agreed upon is that what we're going to do is start at the very beginning. We're not married to not looking at real estate, loan forgiveness. This isn't something that was lost on this committee, but we said we're not going to come out in the first year with every potential scenario and every potential answer from this committee. So you're exactly right, but I think there's a lot of different incentives out there that will be discussed. It's my hope and my understanding that that center that we're talking about here will look, with all due respect to some of the others that are sitting here being here, they're not looking at recruiting here. It's not one of their, but if you've got a rural health center, maybe they can sit there and actually survey and go, what would it take for you to get here? Instead of just taking a guess at an answer of what potentially it might be. So I'm just optimistic, because we are saying we're not limiting ourselves one way or the other, and we're going to do what's in the best interest of creating a healthy environment for all of Georgia.
And I'd like to add, Chairman Reinders, that Martha Wignan has a spreadsheet of all the recommendations, and I think a checklist beginning to start of things that we do. Oh my goodness, it's a lot, but it really gives us a blueprint of, you know, if we're going to address the needs of rural Georgia, these are the things we need to look at. It's really neat to look at.
We're gonna build a hotel and a restaurant that's open 7 days a week down in Laricchio's area.
I bet there already is one there.
No, I got in trouble about asking about it like that. It's a little private jokes. I mean, you know, some of the industry down there's no hotel for them to bring people in, and there's no restaurant that's open 7 days a week or something. Remember that one?
No.
And I
forgot. Yes, ma'am.
anyway, so some of those suggestions were a little out of range for us to do on the state basis, unless we're gonna build a hotel. So anyway, but we got lots of really, really good ones. Okay, we have people that want to speak on this. Ethan, do you have anything else to say?
Yes, ma'am, I do.
Okay.
Madam Chair, I'm Ethan James with the Georgia Hospital Association.
And if you're going to read all it on those
official.
pages, I'm going to make you sit down.
I'm not, just a few notes. We represent more than 170 hospitals throughout the state, and I just wanted to emphasize, we do represent all the rural hospitals in the state, and we're proud to speak for them today and stand in support of HB 769. And I want to first thank Representative Jaspers for bringing this forward, and I think he's done an excellent job explaining this bill. There were just a couple of things that I did want to mention and to highlight. I do believe that this bill represents a full and accurate representation of what was discussed regarding healthcare at the Rural Development Council, which I've been part of a lot of study committees in my time. I think this is one of the best I've ever seen. They did such a thorough job, and it was such great participation, not only from the council members, but from all the different communities and all the different stakeholders who did participate in those discussions. Very quickly, I did want to mention, Chairman Reinders, you had mentioned on line 93 the rural healthcare providers and their inclusion in this education. while the penalty and the requirement is for the hospital leadership, as the sponsor indicated, I don't know that it is such a bad thing to have that education available to all rural healthcare providers. And I think that was the intent of including them in this, to where if they want to participate, if it's an FQHC or a clinic or some other rural healthcare provider, and they recognize that the education was important and they wanted to participate, it would be available for them. And I think that's what the State Office of Rural Health would go about doing, is creating that curriculum for all rural healthcare providers. But the
You mean
penalties and the requirements are
the
only for
leadership
this. No, I think for all rural healthcare providers, but the penalties and the requirements are only for the hospital leadership. I would not change that, because I think there are some rural healthcare providers that are not considered hospital leadership that may want to participate in that. So I think the curriculum could be developed for that inclusion. And then just to highlight on line 101, and again, Representative Jaspers did highlight that this is the loss of Medicaid funding.
Real quick, I say it's, I'm trying to find the right way of doing this. I don't want, when we're talking about rural health care, for the decisions to be made just by the hospital when we're talking about other, and I know you're talking about the education piece. So as it relates to the center, I didn't want that made up exclusively of just hospital personnel.
I don't believe that is.
I understand, but I didn't see anything that didn't. I wouldn't want the same board potentially dictating to another provider to say, you must come take this education.
Right.
Right, and that's not what this says.
That's a second,
Right.
And I just don't see anything that, and that's why I just favored us having a mechanism to go back in. You can never anticipate every unintended consequences. I've learned that up here.
Indeed.
And so then what happens is we have to come in and we have to take potential corrective action or oversight or whatever, and I didn't see a mechanism for that. I'm going in with great optimism, but that was my concern. I wanted that board to be broadly based other than just.
And I don't think this is. I think it's the State Office of Rural Health. That's not hospital leadership. That's the administration under DCH, and this new center would develop the curriculum to make sure all rural healthcare providers were appropriately trained. But it is only the hospital leadership that must participate in this training. But everybody could take advantage of it, and I think that might be a good thing.
And that could be good.
I know hospitals do interact with the other healthcare providers in rural communities that are not necessarily associated with the hospital, but that's a tight-knit community, and they do interact. And if that training was available, they may want to take advantage of it.
Thank you.
Again, just to emphasize on line 101, we do believe this is a stiff penalty. The loss of Medicaid. When you say you cannot receive state funds, you're talking about Medicaid funds. That hospital would be ineligible, perhaps just because of an error of a single board member who did not complete the training requirements. The entire hospital, and thus the entire community and all the patients would almost immediately be without a hospital. That hospital would not survive another month without that Medicaid funding. That follows the patients and the patients they treat. If they could not get paid for serving those Medicaid patients, they wouldn't survive. So I just did want to point that out, that is a harsh penalty because of the mistake of a single individual. The entire community would suffer. The CON section, the micro hospital section, I did want to make this clear. GHA has a long-standing position to protect CON, but what we mean by that is not to erode CON. We don't want the program to change and open it up to erode the important aspects of that program. I don't believe this is an erosion of CON. I believe this is an important codification of, as Dr. Newton did point out, what is already available, but it presents a clear path for these hospitals to take that is in the code and not subject to an administrative decision like it was for a hospital who did go down this path. It would be an important codification of that and present that clear path. And I think I did answer your question about this is currently available. And Madam Chair, I think you had a question about the busy ERs. I still do believe that the ER is very, very important for these communities. If it's a flu case, which is crowding a lot of our emergency rooms right now, that is important. If
I'm not
again,
questioning whether they're needed or
I-
not.
I
I'm questioning the affordability. When we started talking about some hospitals not, being owned by a bigger hospital, whether that was an affordable option or not, or an urgent care, if that would keep them from, this says open, an emergency room open 7 days a week, 24 hours a day. I would think that that would limit a small hospital that wants to go down from having a more, a pretty extensive urgent care center. But that would not reach the definition of an emergency room.
yes, ma'am.
But urgent care would be a place where somebody could, where they could be evaluated and then moved very quickly on or something. But, so I'm not questioning the need for them.
Right.
I'm just wondering if it's limiting, and I think that's something we need to look at.
Thank you. I believe Andrew Johnson with DCH did answer the question about the CON and the purchase of the hospital. And then finally, just to reemphasize the importance of that rural hospital tax credit, as the sponsor did say, only $10 million was claimed at the 90%. The inclusion of S Corps being able to contribute and moving that up to 100% is critical. A couple of state representatives approached me a couple weeks ago with a stack of letters, 4 inches high, of letters from their hometown hospital community, just community residents, begging them to please move this tax credit up to 100% so that they can save their rural hospital. So I just want to reemphasize that. And Madam Chair, with that, again, I stand in support of HB 769. I urge your favorable consideration, and I'm happy to answer any additional questions.
Any questions? Okay. Thank you.
Thank you, ma'am.
Thomas Worthy?
Madam Chair, members of the committee, I'm Thomas Worthy. I'm VP of Government Affairs at Piedmont Health System. Piedmont Health System is a nonprofit community health system comprising of 8 hospitals across North Georgia, serving 2.2 million Georgians. More importantly, for the purposes of this conversation, I believe, is we were the hospital that opened the Georgia's first freestanding emergency department in Ellijay when North Georgia Medical Center in that community decided to close. That process was drawn out, labor-intensive, time-intensive, and had a lot of associated attorney's fees. So to echo Ethan's point, I think it is important to note that this is available today. This is available today when we have done this. But like I said, it was very, very costly. It was very, very time-consuming. And I think it's very important to codify this, to clarify this as a route for rural hospitals to take, especially given 11 months from now, we're going to have a new governor, perhaps new administration at DCH who may interpret rules and regs differently. Secondly, I want to say that this is not the silver bullet. This is not the solution to everything, but it should be viewed by the community or by the committee as it is with the hospital community as another tool in the toolbox to give those communities an ability to have financially stable facilities delivering care close to home that gives longevity for the communities that it serves. And then thirdly, I want to echo Ethan's point that it is so narrowly tailored that it does not erode CON because like GHA, like the Alliance, Piedmont stands in strong support of the state's health planning program. But this actually may even be an avenue to keep that CON in a community because if it's downsized, the CON will remain active with the facility. And if that facility, if that county then grows and that needs to rise back up to the level of need that it originally had, that would be an option. So as someone, as a healthcare system that has done this and has learned the good lessons and the bad lessons, Piedmont strongly supports HB 769 and urges your favorable consideration.
Well, that's a good point to bring up, that if the community prospers and grows, that you can expand back up to the whatever limitation that the CON had before. Nobody's brought that up. Thank you very much. Any questions for Thomas? No. No questions? Okay, thank you. Tim Kibler.
Thank you, Madam Chair. I'm Tim Kibler with the Georgia Alliance Community Hospitals. We're an 85 hospital
Association of Georgia's Not-for-Profit Hospitals. We very much support Representative Jasper's House Bill 769. Would ask you to do the same. In the interest of time, Madam Chair, I'm glad to be cut off and then let the next person testify, but I'm also glad to answer any questions anybody may have.
Any questions for Tim? No?
Thank you.
Okay. Rondell Jaggers, that's, have to get it right? Tell us who you're with.
Thank you, Madam Chair. My name is Rondell Jaggers. I'm here with the Georgia Society of Health System Pharmacists today. Really want to thank Representative Jasper for his work on the bill, and I think we've had some conversations with you earlier about a couple of nuances in the bill that I want to try to address. For those of you who don't know us, GSHP is a professional society of pharmacists and technicians practicing in hospitals and organized health settings throughout the state of Georgia. Our members include large, complex academic medical centers as well as smaller rural hospitals. I've been a licensed pharmacist since 1983 and have practiced in 9 hospitals over a 35-year career. My first director of pharmacy job was in a small hospital in Maysville, Kentucky, and so I have a little bit of a perspective on some of the smaller places. Couple of things we would like to propose. Line 17 authorizes remote order entry from outside the state, and I think that's been since changed to say within the United States. Is that correct?
Yes, sir.
We still have some concerns about outsourcing patient care services to out-of-state facilities. And so we would propose leaving remote order entry services within the state of Georgia and would appreciate that consideration. Line 34 also proposes to change the conditions for use of remote order entry from will be physically present in the hospital pharmacy. Currently says 24 hours. I believe the latest proposal is the next business day. Is that correct?
Yes, sir.
Or the next business day.
Yes, I'm sorry. We respectfully request that the committee not change the current 24-hour time frame. Our concern is extending that period of time that a pharmacist is not present in the hospital allows medication errors to self-perpetuate for a period of perhaps multi-days, up to 3 days if I understand what next business day means. So that in turn increases the potential for patient harm if those things go unnoticed. And then my experience would be in those smaller hospitals is if you find those things within a 24-hour time period, you're able to correct them and recover them pretty quickly. If you go 48 hours or 72 hours, there is some potential for things you can't recover from as quickly. So, and again, all respect to Representative Jaspers and the work he's done. You were much more articulate about remote order entry than I think most pharmacists would be. So you've seriously done your homework on that. So,
Okay.
Questions?
Yes, Representative Reinders.
Thank you so much. Did you address your concerns with the author of the bill and beforehand?
I did not, but I believe one of my colleagues did.
Yes.
I called them on last week. Yes, sir.
Okay, so I'm going to defer to the chairman on that. And since we'll pass this bill out, I'm assuming, because it's such a good bill, then I would encourage to look at those differences as we move over to the Senate.
Well, wait a minute, could I inject something here? I think the problem that we have is we're talking about rural hospitals, and we're talking about in areas of state where we don't have a whole lot of pharmacists, and they don't want to work weekends after they worked a whole week, or the cost is just astronomical to get somebody to work. And I think that is why, if you go at 5 o'clock on a Friday afternoon and 24 hours, that's 5 o'clock on Saturday. So that's why, they were saying, or the next business day on Monday, I understand, but getting pharmacists to cover locally is one of the problems that we had, and I believe that was a major problem, was it not?
Yes, ma'am, and just to continue to address what you said, if you look on line 43, it's currently being done. The greater than 24 hours is being done, remote order entry by large hospitals that may have up to 4 outside of in their connection world.
So, if you start, it's just a predicament. It's sort of like doctors trying to find them in the rural areas, and if it becomes a problem and it's documented, we go back and change things, I would say. But right now, this was a major concern. for the rural hospitals.
Very good.
Thank you.
you for listening.
What?
Thank you for the opportunity.
They're
Yes,
there
sir.
just out with a gun hunting deer.
Okay,
Deer hunting.
thank you. Do we have a question? Who? Oh, Representative Lott, sorry.
Thank you. I'm going to ask, appreciate the opportunity for the chairman here. I think he brought up a point that I have just a question about, which is this within the state of Georgia versus within the United States on their ability to do the remote entry. I ask this question only because repeatedly in this very committee, we are about restricting everything into within the state of Georgia. We did this when we had our discussions on the dentists and the dental hygienists, and we've done this in the past where everything we try to draw into the state, we talk about employing our own and taking care of our own and making sure that we're getting that managed. And now for this one, we've opened it up. And just out of curiosity, what's the reason for that?
That's the standard. If you look on the page that I handed out, that's the standard by their own association, that it should be within and across state lines for appropriate practice settings. And this is very clear that the Association for American Society of Health System Pharmacists, that's what they say should be done. And it does allow for in-state, out-of-state, just like we do for radiology. There's many things that have become technology used that this is done in.
Thank you.
Yes, ma'am.
Okay, Michael Azolan, I'm probably killing that, I'm sorry.
It's Azel.
Azel?
A lot of folks call me Azolan, that's okay.
Pardon?
A lot of folks call me Azolan, that's okay.
Azolan.
But it's Azelin, yes,
Oh,
Azelin. So yeah, I'd just like to reiterate a number of things that have been said here, particularly what you said, Representative Cooper, about the bill, and I also thank you, Representative Jaspers, for authoring this bill. My name is Michael Azelin. I'm with PharmD On Demand. We founded our company in 2006. We are a remote pharmacy services company located out of Watkinsville, Georgia. I'm a graduate of the University of Georgia College of Pharmacy. Whenever we founded our company in 2006, we had no contracts and we serviced no hospitals. It took us until November of 2007 to get our first contract, and it was in Dayton, Tennessee, because the Board of Pharmacy in the state of Georgia would not allow remote services to exist. Fast forward to now, and we now have about 116 employees. 114 of them are in the state of Georgia, and about 48 of them are pharmacists. And we service over 20 hospitals in the state of Georgia, all rural. In these hospitals, in all of them, prior to the law passing in 2012, in these rural facilities, the pharmacist left at 5 and no one came in until Monday at 8. So to Mr. Jagger's point, he's exactly right. A pharmacist needs to review those medications before Monday. What Remote Pharmacy Services does is allow those medications to be reviewed by Georgia licensed pharmacists prior to administration in those hospitals. In all hospitals in the state of Georgia, nurses are administering the drugs. They retrieve them in most all hospitals, with very few exceptions, out of automated dispensing machines. The medications, once approved by pharmacists, are profiled on those machines to promote safe retrieval and administration of those drugs. In the event that a pharmacist doesn't do the electronic review that Remote Pharmacy Services allows, then that can't happen. And it increases the opportunity for mistakes and patient harm. As Representative Jasper said, we're a three-legged stool in healthcare. You've got doctors, you got pharmacists, and nurses. If one piece is missing, then there's a chance for a Swiss cheese model to occur where something gets through and causes patient harm. I can give you several examples. But before I do, I want to reiterate something else he said. The American Society of Health System Pharmacists is the parent organization of GSHP, and their recommendations as of June 4th, 2017 specifically, and I will read them to you. You have them in your packet. State that ASHP, this is their statement on telepharmacy, that's what they call it, and past this, in a different paragraph, they define telepharmacy and give the synonyms to it, including remote order entry and remote pharmacy services. 5 sentences. ASHP believes appropriately trained and equipped pharmacists can use telepharmacy to remotely oversee pharmacy operations and provide distributive, clinical, analytical, and managerial services. ASHP advocates that telepharmacy be applied to suitable functions of pharmacy operations and patient care to improve patient outcomes. Remote pharmacy services improves patient outcomes, as evidenced by all of the articles cited in this article. expand access to healthcare, and enhance patient safety. ASHP further advocates that boards of pharmacy adopt compatible regulations that enable the use of United States-based telepharmacy services within and across state lines for appropriate practice settings, and that further research be conducted to establish best practices in telepharmacy. One of the reasons to go across state lines, let's say that us as a company, we want to hire an infectious disease specialist pharmacist that's been postgraduate. After their graduation, they've done 2 years of residency in infectious disease, and there's not one readily available in Georgia for us to hire. But our rural hospitals want an infectious disease specialist pharmacist to review their infectious disease antibiotics that are being provided to patients. If we need to go outside of Georgia to hire a Georgia licensed, again, they have to be Georgia licensed. They can't be Tennessee licensed and not Georgia licensed. So there are Georgia practicing pharmacists, and they could drive into this state and work. If we had to go outside the state and hire them to dial in remotely and review those medications, it would give those rural hospitals an asset that they couldn't get otherwise. I can cite several examples. I don't necessarily think that's appropriate or necessary at this time. If you would like for me to, though, I'd be happy to, of actual things that have been done by remote pharmacy services and remote pharmacists. I will say that one of the things that pharmacists do whenever we do that order review is we intervene. If a dosage is inappropriate, if there's an adverse drug reaction, an allergy, an IV incompatibility, or if the patient should not get that drug for some coexisting condition or because of some other medication they get, we intervene and we ask for a change. Sorry about that.
It's okay, we're just running out, I'm gonna lose.
Well, I'm gonna finish real quick. Those interventions in our company, we've done over 9,000 times in Georgia hospitals in the past 12 months. Thank you. If you have any questions, I'll be happy to answer them.
Any questions? No. Okay, I'm worried about losing my thing. Thank you very much.
Thank you.
Okay, I'm ready for Representative Reinders.
Appropriate time, Madam Chair, I move, do pass, and I offer a friendly amendment.
Okay, let's get we've got a do pass. Do I have a second? Okay, now we have a proposed amendment. Everybody?
Many in the audience will think that I actually wrote this, given my great legal mind,
Yeah, right.
but actually, oh, you should laugh louder at that, but thank you, Ms. Betsy, because I don't know what I'm about to read, but on line 93, we're going to scratch to rural health care providers, and in its place, to leadership of rural hospital organizations as defined by Code Section 31-8-9.1, comma, and to other rural health care facilities upon request, which I think helps the Ethan part that
Right.
says if others wanted to do
It's
it as well.
available to other people.
Yes. And I look for someone to favorably second that.
Second? Okay, we have a motion. Any discussion on the amendment first? Okay. Okay.
Question about the amendment. Did you say to other healthcare facilities rather than to other healthcare providers?
That's clearing up. The providers are like doctors and nurses and that kind of thing, so it's facilities.
So are providers still able, included at all?
And other rural health care providers, facilities upon request per Code Section 31.8.9.1, which I read last night.
Okay, great. Thank you.
Okay. Let me see it. What is it? Okay. All right, here we go. All right, any other questions?
So let me ask clarification. This means that if you got one doc and someone else running the hospital, they can still qualify under this?
They're running the hospital?
Yeah, because in small community hospitals, you're not gonna have administrative staff. You're talking about 3 people probably,
They-
not Hollywood and.
They have to take the courses. I mean, when they're gonna
Right.
set up things for
Right.
them to take.
Right. That would include the doc too.
Well, yeah,
If I may add, I know Legislative Council knows our intent, and if she is fine with it, we're sure fine with it.
yeah.
I'm sure you.
She
thought
was, I mean,
Okay.
to make it right.
Okay.
Okay. She wrote it. Reinders
I
didn't
know,
write
I'm
it.
just
You
putting an
knew
amen.
that.
I'm just putting an amen on
Do
it.
you think I would approve something that he wrote?
Well, I just want to say amen. That's all I'm
Where is
saying.
your faith in me? Come on,
Oh, I saw
Jaspers.
him pass it.
All right, there's no more discussion on the amendment, so everyone in favor of the amendment, say aye.
Aye.
Anyone opposed? No. All right, now we have a motion and a second to move the substitute to House Bill 769. That's correct. LC 337321S. Any further discussion? No further discussion? Everybody in favor, say aye. Anyone opposed, say no. You got it. There you go.
Thank you,
Representative
committee.
Jaspers.
Thank you for
We
for
are
the time.
adjourned.
We appreciate it.